You have Mary's bio in the program, but we're super excited to have Mary here because she has been doing so much work in the space that you're going to hear about that can help our kids understand their neurodevelopmental and neuropsychological testing and all the related issues that come with that. And I just wanted to note that after this session, we're going to do a brief closing because we didn't want to do the breakouts and have you guys come back in here. So we're going to close out the session after this. And then if you are staying on for the special education survival guide breakout, it's happening in this room. But if you're going to the vocational rehab breakout, it's across the hall in the Russell room. And so just go to your breakout that you want to go to. Both of them are going to be recorded, as I said earlier, so you can, you don't feel like you're missing content, and they'll be accessible after the conference. At 3:30, you have to take all of your stuff out of here, and just, if you want to keep talking, just do it outside of this room. And so with that being said, thank you so much for being here.
So my name is Mary Wojnaroski. I am a psychologist at Nationwide Children's Hospital in Columbus, and I specialize in the evaluation of children and young adults with neurodevelopmental disability, so things like autism, ADHD, global developmental delay, intellectual developmental disorder, and I do a lot of work with kids with those conditions who also have rare genetic epilepsies. So I'm really grateful to be here today. I have been so moved by the stories that were shared this morning, the stories of strength and resilience, but also vulnerability about the tough moments and being able to hold space for those. So thank you for inviting me and sharing in your talks today. So let's see. Oh, is this? I actually don't know how to do this. It's the big green arrow. The big green arrow. That makes sense. So I have no disclosures. So here are my objectives today. So really going to talk about some of the neurodevelopmental disorders that are present in CACNA-related disorders. Tips from the trenches, I don't know, I really played with what to call this section, like words of wisdom or lessons learned, or I'm not sure, but things that I have learned along the way from my experience and from families' experiences. I also have a notepad to take down any lessons learned that you would like to share with me to enhance my learning, so I'm excited to talk about that. The purpose and the components of what an evaluation looks like, common diagnoses, and then just a little bit about IEP and school services. I know we have a session dedicated to that after this with, sounds like some real experts in school advocacy, so I'll just talk a little bit about the overlap between like medical or hospital-based assessments. My goal for today, I guess, is to really uncover like the black box of evaluations. I don't know how familiar you are with them or what we do or why we do them, but hopefully providing some information about the process so that you all can be informed consumers and advocates for your children when and if you go through this process. So I'm just gonna talk about this really quickly. I think you all probably know, but these are some of the common neurodevelopmental and mental health disorders in CACNA 1A related disorders. So global developmental delay or intellectual developmental disorder, which is the new term for intellectual disability, if you've all heard that. Autism spectrum disorder and ADHD, some of the conditions that I mentioned, but some individuals also have depression, anxiety, OCD, and I know one that's a really big concern is a regression in skills or a loss of developmental skills that were gained and then through neurological events, hemiplegic migraines, intractable seizures, sometimes kids lose skills that they've developed. So here are my tips from the trenches. Get a neurodevelopmental or neuropsychological evaluation early. Don't wait. My experience is that certainly for kids who have complex medical needs, so much of their early life is focused on on life, right? Treating seizures, treating other medical conditions, respiratory issues, motor difficulties, and all of that is obviously very important, but development is happening or not happening also at the same time. So I do hear, like, sometimes let's wait for the evaluation until the kid's a little bit older, or maybe thinking that an evaluation won't be helpful or meaningful in a young child. But really, we want to start evaluation young so that we can monitor development over time, and also start helping kids get access to therapies and interventions as soon as possible. This is a really big one. Development is a dynamic process. So, and we'll talk about this in a little bit more detail, but we are expecting more and more from kids as they get older. So if I see a child at a young age and they're developing, typically that's great, but also they need to continue gaining skills at that same pace to be in the average range for age expectations as they get older. So that's one reason that repeated assessments can be helpful, because what we're really tracking is learning over time, not just a score on a test or what a child can do at one point in time, but understanding that pace of learning or the development of skills over time can really help me as a professional really make sure that I'm understanding more about your child, their pace of learning, and what interventions or recommendations might be most helpful for them. This is related, so delays may appear with increasing expectation. So as I said, we're expecting more and more from kids as they get older, and so kids are often learning, they're just not doing it at the same pace as typically developing peers, so the gap can widen as kids get older. And it's not that they're losing skills, it's just that delays are becoming more noticeable as they're falling further behind in expectations for their age. Be a partner in the evaluation. I think we've heard a lot this morning about how you all are the experts in your child, and sometimes experts in CACNA 1A. You know, I will say I'm not an expert in CACNA 1A. I've learned a lot from this conference, and I hope to continue to learn more. But it is so helpful when a parent is actually in the testing room, especially for kids who have really unique learning styles. You know, the first time I meet a child, I certainly don't know as much as you do, right? So if a parent can be there and provide information that helps me tailor my assessment to that child, that's so helpful. I know we've talked about being an advocate, and that's definitely one way to be an advocate. You know, my child cannot see that picture that you're asking them to look at, would be a really helpful piece of information, and hopefully you'd be working with a psychologist who was receptive to that. We often do assessments without the parent in the room, and that can be really helpful, because kids a lot of times do better when their parent's not in the room. But if they're like unique learning styles or conditions or things like that your child benefits from, that you've learned through working with them or in the school, I'm not gonna know that. So I really want to hear from you about what works for your child. This one I think is a big one. Scores and diagnoses are important, right? So scores on developmental tests, diagnoses, that's a language that we use as psychologists, educators, medical providers. It's a way that we communicate with each other. So it is important, and it also often gets access to services. But really understanding your child's specific skills and the support that they need is most important. So I think a big job of mine is to figure out what a child can do, not just tell you again that they have delays. Like, that's not helpful, right? So especially for kids who have we've talked about inch stones, you know, especially for kids who are developing at a much slower pace than their peers. You know, an evaluation to say that child has delays is not as meaningful as these are the skills that your child has. Here are the skills that are next in their developmental trajectory that they're ready to learn, and here's how you can help them move forward. And then make sure intervention goals are a match for your child's developmental level. I think this is really important, you know, really understanding the skills that your child has, and they may be average in one area, below average in the other, really delayed in another, above average in one. And so really understanding and making sure that we're targeting goals and interventions that are appropriate for that child to learn. So why should my child have an evaluation? I think there's a lot of good reasons. And I've talked about some of them already, but obtain behavioral developmental diagnoses. So developmental and behavioral diagnoses can be part of a genetic condition, but they're not the same as a genetic diagnosis, which I think we heard this morning. And I think about it, it was nice to hear it framed like intellectual disability or intellectual developmental disorder. There could be lots of reasons an individual has that diagnosis. It's not the same as a genetic diagnosis. But for me, having a genetic diagnosis doesn't mean that you have a neurodevelopmental condition. It can. It places you at risk for it, but those two are not the same thing, and they get you access to different services and a different level of understanding about your child and their needs. Track skills over time. I mentioned that, particularly regression. Sometimes one of my roles in the hospital is to evaluate a child and see if they've had a regression or a loss of skills, and that's a really important question that I'm asked to help to support a different intervention. Track response to intervention. Is this therapy? Is this medicine? Is this working? Is this making a change in my child's development or behavioral presentation? Determine strengths and weaknesses. I already mentioned that a little bit, but I think that's really important. As a medical provider, it's so often our job to find out what's wrong, what's not going well, and in the interest of helping that, right? But it's really important that the evaluation take into account your child as a whole and what skills and strengths that they do have. Informed decision-making and treatment planning, informed support services, therapies in school, home, and the community, and access to services, therapies. So I think of my job as a storyteller sometimes, and I'm not like making up stories, but the idea of taking all of the information that's available to me from the medical provider, from the school, from parents, from the diagnostic tests that we use, from my observations of the child, and putting it all together to tell a story that explains and helps us understand that child's developmental and behavioral presentation. And then the idea is obviously to use that information to support that child's growth and development in whatever way they need and what is most helpful. So what are the main components of an evaluation? I should say, too, I wonder if people have questions about like a neuropsychological versus a neurodevelopmental evaluation. So neuropsychologists are psychologists, and they have extra training in brain behavior relationships. So they're really trying to identify these skills that are hard for this child. How is that related to their brain functioning? Which is really important. They often see kids with neurodevelopmental disorders, and then also kids who've had some sort of potential injury, like a TBI, or potentially they had a brain tumor. As a neurodevelopmental psychologist, I have specialty training in working with kids who have neurodevelopmental conditions, mostly from birth, and really identifying and diagnosing and providing intervention and support for those specific developmental disorders. At my institution, we have a really large neurodevelopmental disorder program and then a neuropsychological department. So there's, I think, a lot of, we each have our own specialty, and that's not always true at every hospital or place that you go. So what's most important is that I think that you find a psychologist who's used to, has knowledge working with kids with rare disease or neurological conditions, and then thinking about that person's skills and if they're the best fit for your child's needs. And you can ask, your neurologist or other medical providers or families that you work with. So the four main components of an evaluation are neurocognitive functioning. So that's really like intelligence and problem solving or cognitive development. So we're really looking at someone's ability to solve problems, right? And that is related to a lot of things in our daily life. Behavior challenges, so things like autism or ADHD, social difficulties or behavior problems like tantrums or self-injurious behavior, aggressive behavior. Psychiatric conditions, so mental health conditions like anxiety or depression, and then adaptive functioning. So this is really like an individual's ability to take care of themselves and function in their real world. So things like feeding themselves, using money in the community, telling time, ordering at a restaurant. So those are like the big areas of functioning that we're really looking at in an evaluation. And then, as I mentioned, we're tying that back to the other information that we know, previous assessments that they've had, medical conditions, vision, speech, all of those things are important in trying to understand a child that you're seeing for an evaluation. So why do we need developmental and behavioral diagnoses? I guess I already talked about this, but just because a child has a genetic condition doesn't mean that they do have a developmental or behavioral disorder or that they don't. You know, I've definitely run into families that have been told, well, your child has this genetic condition and that explains what they're doing. But the genetic condition really, you know, describes the medical condition that's going on, whereas a diagnosis like autism or ADHD or developmental delay really describes the behavioral presentation of that child. And just because you have one doesn't mean that you have the other. So they describe different components of a child, and it's important to have both of them if they're relevant. So how do we make diagnoses? We have tests and checklists and play-based assessments, and we're putting all of that information together along with what we hear from parents or caregivers. A really good, thorough clinical interview is critical to help me interpret the testing data that I get. So they're behaviorally defined. We have the DSM, the Diagnostic and Statistical Manual, and it lists all of the mental health and developmental and behavioral diagnoses that exist. And so we're really keeping that in mind as we're making diagnoses. Unfortunately, there are no objective tests for a developmental behavioral diagnosis. There's no blood test or brain scan or I don't know, anything that's going to tell me, yes, this child has this diagnosis. So evaluations should be really thorough and complete to make sure that we're landing on the best diagnosis for that child. But we're really describing and defining a clinical phenotype or a behavioral presentation. So what are the specific components of an evaluation? So I mentioned a thorough clinical interview with the parent and the child, of course, if they can participate. So it should be a really comprehensive developmental and behavioral interview, asking from early life, so birth history, really like infant and toddler development, those big developmental milestones, all the way through specific areas of functioning, like how is the child communicating now? How are they getting along with their peers? What's their emotion regulation? Like how do they handle difficult situations? What's their ability to cope? And then certainly we're also asking about adaptive functioning, again, that ability to get around in their world, as well as things like feeding and sleep, so that we're really getting a whole picture of that child. I think as a psychologist, I can learn a lot from hanging out with a kid for a few hours, but it's only a few hours, right? And I'm very aware of that really parents are the experts in their child, and I have to get that thorough interview about what your child is like, you know, the 99.99999% of the time they're not in my office, so that I can put that together with what I'm seeing. Reviewing records, so I talked about this, medical, developmental, and school history. I really want to have a good understanding of other issues that are impacting your child or other settings that they're in, how they're learning and behaving in those settings. Direct standardized testing, so we give specific developmental tests or tests to look at specific areas of functioning, and we use those scores to help us understand if a child has delays or not. Clinical observations of the child's behavior, just talking to a kid, hanging out with them, playing with them, having a conversation with them, seeing how they interact in that setting is really helpful and important. Parent, teacher, child, and rating forms. I know you guys have probably filled these out before and you hate them, so I'm sorry, but they do give us a way to get as much information from you as possible, and really then helps us understand if the behaviors or the symptoms or the challenges that you're seeing in your child are appropriate for their age or not. As I mentioned, we don't have a blood test or a brain scan, so I need as much data as possible to try to make the most appropriate diagnosis. Then after all of that, there's a feedback. There should be a feedback to review the results of the testing. So that's usually a separate appointment where after I've evaluated and analyzed and put together all of the data that I've obtained during the assessment, we have a feedback and we go over that to review the results. There should be a written report. So that report has all of the data that was collected, the interview that the parent shared, and then the diagnosis and recommendations. And that is a document that should be meaningful and helpful to you and to providers that work with your child. So I usually give several copies to parents. I tell them to make copies and hand it out to anyone that works with their child who might benefit from learning more about their developmental and behavioral functioning. And then usually we're sharing that report with the medical provider who made the referral to us. So it's a long process, but it should be, right? As I mentioned, we have to put all of this information together, and that takes time. So, just a 1 hour or 30-minute appointment is often not enough to answer all of the questions that you have about your child's learning. So these are the domains of functioning that might be covered during an assessment. So they're not always necessary or relevant for each child, but these are the areas that we're often looking at. Intelligence, language, motor, I think those are often like the big ones. Those are the ones that I want to start with and that I want to make sure that I'm getting. Then academics, how are they doing in school? Memory, which is just what it sounds like, their ability to learn and remember information over time. Visual spatial functioning, so that's looking at information, being able to perceive it, and then understand how it relates to each other, like how things are related to in space, and also to be able to recreate that with some sort of motor task as well, like writing or Legos. Attention, executive functioning. We have executive functioning tests and tests of attention. They are helpful, but they often, it's hard to mimic the attention demands that are required in the real world in a one-on-one setting. My motivation, my goal is to assess that child's best performance because I want to know in the moment what they're capable of. When all of the conditions are best, what are they capable of? I use the parent information to understand, the teacher information to understand the demands that may impact that performance out in the real world. And so measures of attention and executive functioning are sometimes we don't see the difficulties that a child might have in the real world on those standardized tests in our office. Adaptive functioning, I mentioned, that's usually an interview with a parent or a rating form because we're asking about things that I'm not going to necessarily see in the office. And then social emotional functioning, so ability to engage with other people socially, to demonstrate interest in social interaction, to play, to recognize how other people are feeling, to have a social conversation. And then emotional functioning. So a lot of kids that I see have difficulty with what I call emotion regulation. So that's your ability to like recognize how you're feeling and use some sort of problem solving skill or coping strategy to calm yourself down. So you're regulating your emotions. And that can be really hard for some of the kids that I see. Minor things may be upsetting. They get upset really easily and then have a hard time coming down. So choosing the right assessment tool, this is a big one. So there are probably, I don't know, 1,000 different tests that I have available to me to use. We don't have all of them in my office, but there's 20 different IQ tests, and so it's important that I choose the one that's the best fit for that kid that's in front of me. And it depends on the referral question. Why are they coming to me? What is the question that's being asked of me? Their medical condition, because there are some things that might be on a test that might be hard for a child to do or that might get in the way of me seeing their actual intelligence, which I'll talk about in a second. But I think the biggest thing is that assessments used should match the individual's level of functioning. I think in CACNA1A and some of these other rare genetic disorders, there's a very variable presentation in terms of intelligence and functioning. So I can't just say, oh, well, this kid has a CACNA1A related condition, so that means I should use this test. I really need to understand the child's developmental functioning. And I think the biggest one is I see many children who are at the severe end of the spectrum, so older individuals who are functioning like at a much younger level, individuals who have difficulty walking and talking. If I have that kid in my office and I give them a whisk, maybe you're all familiar with that, but it's a really standard, wonderful IQ test, but that child is not really going to be able to interact with that tool and show me the skills that they have. So it's really critical that we're using a tool that matches the child's developmental functioning, and often that means using a test that's developed for infants and toddlers, because that's the developmental level that child is at. And, it's important that psychologist be able to pivot in the moment. If I have a plan based on what I've read in the chart, and then that kid comes in and I need to switch, then it should be on the psychologist to switch, right? To make sure that assessment is meaningful. And as I mentioned, the goal is not to identify a delay. Oftentimes that's people are already aware that that child has a delay in some area of functioning, but really to identify the specific pattern of strengths and weaknesses. How does your child learn best? What's hard for them? What are they good at? And how do I put all of that information together to make sure that I'm generating individualized recommendations to help your child move forward and be the best that they can be? This is really important. Neurodevelopmental, neuropsychological, cognitive language tests, they require things that they're not necessarily part of intelligence, I guess. So we heard about like CVI especially. So there's so many skills that are required to participate in an assessment, right? So I'm going to show the child a picture and ask them, what is this? If that child has CVI or some sort of vision loss, that's not really a fair question, or we're giving instructions with words, right? So for kids who have a hearing loss, they may not be able to hear what I'm saying, and then they can't answer the question that I've asked. A big one, I think, is also motor difficulty, particularly for those infant and toddler assessments. There's a really heavy load on motor, like stacking blocks, doing puzzles, picking up objects, and so if an individual really has a difficulty controlling their fine motor movements or engaging with, or even having the ability to like hold themselves up to sit at a table to touch the things that I'm giving them, if I'm asking them to do these things, I'm already setting them up to not answer correctly, and I'm certainly not assessing their skill. That being said, those difficulties can certainly impact learning in the real world too. So it's a real balance of making accommodations that fit that child's specific needs so that you can really get a picture of what they're capable of doing. I'll use a black background. I think that was mentioned today. So there are lots of accommodations and things that we can do to help support a child be able to access the test so that we can get an accurate picture of their skills. So adaptations are critical. So choosing the right tests, we've talked about that. We've also talked about parent involvement and how helpful you all can be in the room to explain. Even like, some children may make a sound and that means something. But if I've never met that child before, I'm not going to know that. I might have a good guess, right, or figure it out. But if the parent is in the room to provide me that information or that education, that can be really helpful. So there is a difference between accommodations and modifications. So accommodations improve access to the test without modifying the construct. So I might talk louder, right, for a child with hearing loss. But modifications are where you're actually changing the test. Tests should be administered in a certain way. So if I'm doing something like using a different material or using an item that is really important to a child or that they're familiar with, that's a modification to the test. And it's important to do, right? If I administer the test in a standardized way for someone who can't access the test in that way, I'm not going to learn anything. My job is to identify accommodations and modifications that allow me to see this child's level of skill and learning and then turn that into recommendations to support them at school or at home. So I mentioned the feedback. This is a really important appointment to review the results. I will be the first to say that our reports are long, and there's a lot of information in there. I will tell you there's like a movement in psychology to try to make reports shorter and more accessible, but it will be a big change, and of course, and unfortunately, that takes time. But that appointment is a really good time to talk with the psychologist and to hear from them directly about what the results mean, to be able to ask your questions and really gain understanding rather than just reading this 10-page report that has a bunch of a lot of stuff in it. So, but you should receive a written report. That's important to share with other people that are involved in your child's care. One thing that I find is that I find myself wanting to share as much as I can during a feedback appointment. They're usually an hour, and so I'm talking a lot because there's a lot that I want to share. And sometimes, I know even when I go to my own doctor's appointments, I can't remember half of what they said. So the written report is a way to go back and look at what was reviewed as a reminder for that. But also, it's perfectly acceptable to ask for a second feedback appointment. We talked about this, and I understood these 3 things that you said, but I have these additional 10 questions, and I want to come in and as that's percolated, or you've processed it, or you reviewed the information in the report, and questions arise, it's absolutely okay to call and ask for a second feedback. I think earlier in my career, I did a lot of first-time autism evaluations, and we learned some research that often after you say autism, parents hear nothing else that you say. So that's the time when I'm like, here's what you should do to help your kid, right? And if that message doesn't get through, then the evaluation wasn't as meaningful as it could have been. So I'm always more than willing to schedule a second, third, however many feedbacks are necessary. Or if it's just a quick question, phone call or something, like that's fine too. So I loved the talk this morning about asking questions. Here are some questions that I think might be helpful for the questions that you want answered when you participate in an evaluation, and if they're not answered, which ones that you can ask. So what are the diagnoses and how did you generate those? How will they help my child? Like what does that mean? So you say my child has autism, but now what do I do with that? The diagnosis is really just the first step. You also want to know how they came to that conclusion. Differential diagnosis is a big part of an evaluation. Does my child have autism, or is it ADHD, or is it global developmental delay, or is it anxiety? So you really want to hear the thought process behind the psychologist of how they landed on the diagnosis that they did. Do you think the scores on the measures are valid and true representation of my child's skills? Performance on a test is only as good as the person's effort, right? If I stayed up until like 3 o'clock in the morning and then you give me an IQ test at 6, I'm probably not going to do very well. And it's not that I'm not trying, it's just that I'm exhausted and had no sleep. So also things, like behavioral difficulties or attention difficulties, or maybe there was a seizure the night before, like those sorts of things can certainly impact performance during an assessment. And so it's really important to know if the evaluator feels like they captured a good picture of your child's skills. And I almost always ask at the end of any appointment, do you feel like what I saw today is what your child is capable of doing at home? Is this a representation of what they're typically like? What are my child's strengths and weaknesses? I've mentioned this too. It's so easy, I think, to focus on the delays or the difficulties that a child has, and that's important, right? That's the goal of the assessment, is to identify those difficulties and then generate recommendations for them. But also, it's really important to see the child as a whole child. What do they like to do for fun? How are they a part of your family? What are they good at? And those things are really important to providing a picture of a whole child, but also utilizing those strengths to help them improve in the areas that are hard for them. How does this compare to the previous evaluation? If your child has had a previous evaluation, it's always really important for the psychologist to look back at the previous testing. I mentioned that rate of learning or rate of progress or developing new skills. That's what development is. So it's really important to look back at that previous assessment and make a comparison. So, of course, we always hope that children have progressed, that they're older, they've learned more, they're doing better on our assessments. We're obviously very worried about decline. If a child comes in and is doing more poorly on the assessment than they did the last time, that's definitely something to be really concerned about and to figure out why that's happening. Oftentimes it may be a neurological investigation, right, that you want to talk with your medical provider about to figure out if there's something going on medically, because it's not common to have a regression. And what we do often see is that individuals are making progress, that it's just small, or they're not making as much progress as their peers. So we've talked about inch stones, right? The idea that kids are learning, they're gaining new skills, they're just not doing it at the same rate as their peers. And more. So are the results consistent with what is known about CACNA1A and other aspects of their medical history? Does this medical condition help explain the developmental data that was collected during this evaluation? Or is it different? Is there something else going on or additional going on? How do results inform recommendations, interventions, and medical decision-making? So certainly, I think it's easy to see how developmental data can help set goals and expectations for your child in their therapies or school. But I often talk with the neurologists and epileptologists that I work with, and sometimes that results from the testing will change the intervention or the treatment plan. So that's really important that we're thinking about, does this make a difference for my child's medical intervention? Can you give me 3 things that are a priority to focus on? And I mentioned that I feel the need to share everything that I think might be helpful. But that doesn't mean go home and implement the 12 recommendations that I provided to you today. That's not possible or feasible, or it's challenging, right? So it's really, it can be really helpful to ask the psychologist, what are the 3 things that I should focus on? So that can get you started. And then as you move forward on those things or make progress, then you can go back and try to implement some of the other recommendations. how may these results inform my child reaching their goals? Really understanding, what is this child's level of functioning? What are they capable of doing? And how can I use that information to help them move forward in goals that I have for them? And how will these results inform a good quality of life for my child? I think, again, we talk a lot about what's the difficulties or the difficulties that a child has, but really thinking, again, about quality of life, and that looks different for everyone. Quality of life for the child, quality of life for the family. How can I use that information to make sure my child is living and my family is living a good life? Whatever that looks like for you and your family. So how do I read this report? Like I said, there's a lot in there. I had a realization like a few years ago that I don't always read other psychologists' reports completely. I look for the pieces that are most important, and then I go back and look through the details. I also had a neurologist summarize one of my reports with like 5 sentences, and it was a good summary, so I think he didn't summarize the recommendations and all of the testing data. But the idea that there's some really key pieces of information in a report, all the other information is what supports those key pieces of information. So starting with the summary, I actually put my summary right on the front page now, just so that it's the first thing that you see. And if you only read that and the recommendations, that would probably be enough. And then pick 1 to 3 most recommendations to implement. The scores, all the data, that's the stuff that's at the back that is the information that we use to drive the summary and the recommendation. So I'm not telling you not to read that. Absolutely read it if you want to. But don't let the length of the report scare you away from reading what is most important and what will be helpful. I thought this cartoon was funny. I hope no one's making paper airplanes with my reports, but. I guess this is something I just want to make sure that we're on the same page about. So the way that testing works is that an examiner or an evaluator administers a test. It's a set of questions to a child. And then basically we're comparing how that child does, how many items they answered correctly, to the average performance of other kids their same age. If they answer fewer items correctly than other kids their same age on that test, we're going to say that they have delays, that they're not meeting age-appropriate expectations. So you may have seen like an average score is 100. Anywhere between 90 and like 109 is what we would consider the average range of performance. The tests are not a measure of everything that a person knows, but they're specific items and questions that were developed through a really rigorous research, standardization process to help us identify kids who may have trouble learning. So we really have to make sure that we're administering tests in the exact same way all the time so that we can make those comparisons. Now, like I said, that's the goal, but certainly for individuals who have sensory impairments or behavioral challenges, we may need to modify and adapt to make sure that we're getting that kid's best performance. I mentioned that. I guess I want to make sure that we have time for questions. 15 minutes, okay. So these are some of the scores that you can get from a test, and they're all helpful and meaningful. So standard scores, I mentioned those, that's when or norm reference scores, where we're comparing a child's performance to the average performance of other kids their same age. Age equivalencies can be really helpful, especially for kids who are functioning in the severe to profound range of impairment. Oftentimes the standard scores don't tell a good story for those kids. They're getting scores at what we call the floor of the test, so the lowest score possible, and that tells you almost nothing, right? They have a delay, okay. But age equivalencies have a little bit more variability, so sometimes they can provide more information and more meaning. I think they're most helpful for younger kids or for kids who are functioning in that range. They're less numerically sound as you get older. If you were to say I'm functioning like, my age, that doesn't that doesn't mean as much as if you're talking about a toddler. And then raw scores, that's the actual number of points that a child answered correctly. That's the piece of information that's critical for tracking development, progression, or regression. So if a child is answering how many items they actually answered correctly on the test, that's the raw score. And that's the data we should be looking at to see the progress that kids are making over time. I'm going to skip that. So here are some of the common neurodevelopmental diagnoses, and I just wanted to provide a little bit of insight into what those are and how the information that we should be collecting to make that evaluation or that diagnosis. So global developmental delay, early developmental delays in any of these main areas of early development, it's really only appropriate for children who are 5 and under. So global developmental delay is oftentimes the term that we use for young children who are delayed, but who are at risk for something like intellectual developmental disorder. So if a child still has substantial delays at 5, we really should be thinking about making that diagnosis of intellectual developmental disorder. At that point, IQ is pretty stable. Again, it doesn't mean that a child won't learn and gain new skills. It's just that number on the test or their delay of difficulty is unlikely to change. And that's important to know. It's a hard conversation to have, but I think it's really important if that's the area that your child is functioning in, that you know that as soon as possible. It doesn't mean your child's not going to learn. It doesn't mean they're not going to continue to gain and new skills, or that I can predict, what your child's going to be like as an adult from the score. But it does, I think, really help understand expectations and the way we should be teaching our children and that sort of thing. Early developmental assessments are what we use to make that diagnosis. Intellectual developmental disorder, I've already talked a little bit, but this is substantially delayed cognitive functioning, intelligence, or problem solving on an IQ test, also with difficulties or substantially impaired functioning and adaptive functioning, those daily living skills. So again, this term is new, and it's long, but I like it because I think it actually describes what's happening. Kids are learning new problem-solving skills over time. They're just doing it at a slower pace. As far as the relation between global developmental delay and IDD, it's really hard, and this has definitely happened, and it still continues to happen, and it shocks me, it makes me sad every time it happens, where I see like a 13, 14, 15-year-old who clearly has intellectual developmental disorder, but that diagnosis has never been shared with the family. And so I think it's a hard diagnosis to hear anytime, but it's really hard when that has not been explained to a teenager who's like close to adulthood. And generally, we're doing an IQ test and an adaptive functioning assessment to make that diagnosis. I'll just skip that. So autism spectrum disorder. So this is a developmental disorder that includes difficulties or delays in social communication, and that can be many symptoms, from no speech at all the way up to people who are very verbal, who are geniuses on an intelligence test, but really struggle to engage in back and forth or social conversation. And then, so those social communication difficulties also must be paired with restricted or repetitive interests and behaviors. And that can be, again, any number of ways that that's expressed: repetitive sounds or behaviors, or really intense interests, like really only wanting to do one thing. That's their favorite thing all the time. Sounds, difficulty with transitions. But again, it all comes back to this preference for sameness and repetition. And that difficulty, particularly in social communication, has to be above and beyond what we would expect for that child's developmental level. So one question that I'm often asked to answer is, we know this child has developmental delay. Do they also have autism? And then my job is to identify if they have social communication difficulties above and beyond or greater than what I would expect, or difficulties in that area that are inconsistent with their developmental level. And usually we're doing some sort of structured play-based social assessment. And then ADHD, these are the main symptoms of ADHD: inattention, hyperactivity, impulsivity, emotional dysregulation. You can have inattention and hyperactivity, just inattention, or just hyperactivity. It's usually identified between ages 5 and 6. Sometimes we get concerned about it before a child is 5 or 6, but lots of toddlers and preschool-age children are hyperactive. So we're really not making that diagnosis until it's they're really starting to have inattention, hyperactive difficulties, particularly in school. There's no specific test to evaluate that. It's usually based on parent report and rating forms. So I'll just say there are differences between school and hospital or private assessments. School evaluations are really focused on eligibility for special education services. So it is a federal program, right? The idea that some kids may have extra needs to be able to access the educational curriculum. So there are educational classifications that a child might receive at school. That's very different than a medical, neuropsychological, neurodevelopmental evaluation. We often use the same tests. The process may look the same, but the purpose of the evaluation is different. And oftentimes the hospital-based assessments are really taking into account medical conditions, other areas of functioning outside of the school that are important for that child. I'm going to save this for our special education section. It seems like it might fit well there. And I can talk about, there are some measurement concerns. The tests that we have, they're great. They tell us a lot, but there are certainly limitations to them, especially for kids who have rare genetic disorders, especially kids who are functioning in the severe to profound range of impairment. They just, they fail to measure those kids well sometimes. So I'm actually part of a couple projects looking at improving those assessments that I'm really excited about. Happy to talk with you more about those. Yeah. 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 Okay. Yeah. So I'm working with it's me and then Natasha Ludwig, who's a neuropsychologist at Kennedy Krieger, and then Aaron Kott, who's what I call a psychometrician. Like he's a development measurement guy, right? So looking at the specifics of IQ testing. So the three of us have submitted a grant to understand developmental assessments, what works for kids with channelopathies, really trying to identify what's important to families when we're looking at areas of functioning, and then also how do we best measure those. So we submitted a grant and the CACNA family, the SCN family, and the KCN family. So we're really focusing on channelopathies, and we hope to, although there are definitely differences between those groups, there's a lot of similarities too, especially in developmental and behavioral functioning. So the idea is, can we get a good tool that applies to a lot of people instead of focusing on just one specific gene? If we make a test for each specific gene, it's going to take us forever. So can we find the commonalities, realizing that the differences are important too, but also when we're looking at developmental and behavioral functioning, that similarities exist. So I think the grant was reviewed just this past week, so I haven't heard yet, but definitely have our fingers crossed for that, and we'll be looking for your help and support and participation if that gets funded. And if it doesn't, we're going to try again. So I have some time for questions.
Yeah, and I'll just say that I think I mentioned that you'll be sticking on for the special ed breakout, so
Yes.
if you don't get to everyone's questions,
Yeah. And I'll be here the rest of the day too. So.
Hi there, Deb again. Sorry, I'm a general pediatrician. I just wanted to point out that a lot of our kiddos get diagnosed with global developmental delay, and I didn't know if you could speak to like when does it change from, in your opinion, from GDD to ID? And I would just say my personal experience is that between 6 and 8 is when you should go ahead and get that different diagnosis. So GDD is when like you're younger and you don't really know what's happening. But if by 6 to 8 your child is severely delayed in multiple areas, then they should be evaluated and diagnosed with intellectual disability. But most pediatricians will not bring that up at all. And so I had to fight for like 2 years to get my daughter to get seen by a neurodevelopmental doctor to get her ID diagnosis. And I just wanted it. Like I was like, she doesn't have GDD anymore. Just like technically, like she should have an ID diagnosis. And it was just really, really hard to like many people, like you said, like I didn't really know. So I was calling neuropsychologists and they'd be like, we don't see young kids. We don't see kids that don't talk. We don't see this or that. And so that is a really good point. Like one of the best points is that you need to see a neurodevelopmental psychologist. And I was able to find that at Boston Children's and then had a really good experience. But just what age and like how do you make that decision? And usually it's like a year wait.
Yeah. Thank you for bringing that up again, because it's a really important message. So actually, the DSM says that global developmental delay is no longer appropriate after 5. So I think, around 5 or 6 is often when I'm thinking about making that diagnosis. And sometimes younger, there are certain situations where the child that you're seeing has so much going on. Even at 3, sometimes it can be, it's helpful for families to hear either that you're giving that diagnosis or that it's a likely diagnosis soon in the future. But I would say around 5 or 6 is usually when I feel, maybe even 4, depending on the medical history, is when I feel more comfortable making that diagnosis. But it's a hard conversation to have, and I think sometimes people avoid it, which is,
I honestly think a lot of physicians have no idea.
Yeah.
They do not know like that difference of like 5 to 6. They look at records, GDDs are like 18.
Yeah. Yeah.
So like as a parent, unfortunately, is another area where we have to teach our physicians.
Did you all hear that? Okay.
Our daughter is 2, and she has global developmental delay, and we've seen a lot of regression in her. My question is an IFSP the same thing as the test, the neurodevelopmental test? Is that the same thing as the IFSP, or where can we get one of these, or how do we fight for these?
So in each state or throughout our whole country, there's something called early intervention. It has different names in different states. In Ohio, it's Help Me Grow. I've heard like First Steps or Birth to 3. They're all the same program though, and they usually are developing an IFSP, and that's like early intervention, speech therapy, occupational therapy, physical therapy. That is a state-run program and they might do a developmental test. Sometimes they do, sometimes they don't. In Ohio, it's run by each county, so there's even like more variability in what happens. But they have to do some sort of assessment to say that your daughter qualified for services. But if they're not doing like a formal direct assessment, then I would say go to like a children's hospital. We can talk about maybe where you live, and I could make some recommendations if I'm familiar, but it is different. That's sort of like the school. The IFSP, early intervention, I think of as like school for toddlers. And then once they turn 3, they actually start going to school. But early intervention is like special education for infants and toddlers.
Thank you so much. Yeah, absolutely.